Good evening to all the aspirants present here. Today's topic is organ donation and transplant, and the speaker that we have here is Dr. Varun Arora, who is a consultant at BLK Max Hospital, Delhi. Thank you, sir. So you may start the session.
Thank you, Sana. Good evening, everyone. So, before going into organ donation and transplantation, first we will understand what is brain death. And we have to understand brain death in European context and not in Indian context. Though the principle 95% of the principles are same for both India and Europe, but since all of you are EDIC aspirants and you are giving EDIC exam, so we have to consider certain things in European context and not in Indian context. So first we'll go with the definition of brain death in European context and what is the criteria, what are the criteria for defining death in a patient. It should be noted and it is important and you will be asked that once the diagnosis of brain death is made in a patient, the patient is considered as legally dead and the focus of management shifts from the patient to organ management. Now the patient is not managed, but the organs are managed because we need to transplant these organs to someone else. The diagnostic criteria, as I've already told you, for defining and for diagnosis of death vary across European countries. I'll be mostly covering about the UK part. It as it is because it is difficult to cover all the European nations and EDIC people they focus mostly on the UK guidelines. There is importance of precise neurological assessment, especially for diagnosing death, and there are ethical considerations in death determination. We are going to see it. So in UK, there was a 2008 code, and now they have upgraded to 2025 code, which was released this year on 1st of Jan. So the diagnostic criteria for the confirmation of death was given in this code. There is only one definition of death, but there are three sets of diagnostic criteria. They have added one more somatic criteria. Earlier, there used to be only circulatory and neurological criteria, and now there are three criteria that is somatic, circulatory, and neurological. So, somatic criteria are used following overwhelming physical trauma or when death is suspected to have occurred considerable time before. For example, the patient is decapitated. Obviously, you will not look for circulatory or neurological criteria. The patient is considered as dead. And if the patient has got rigor mortis, so you see that the death has occurred a considerable time before. So this somatic criteria was added in 2025 code this year. So you may get some questions on this. In 2008 criteria, the circulatory and neurological criteria were there and they have been kept as before. So circulatory criteria are used following cardiorespiratory arrest, most commonly in a case of community setting when death is expected, but also in cases of sudden and unexpected cardiorespiratory arrest where resuscitation has been unsuccessful. So in ICU, you can have cardiorespiratory arrest. You have done the resuscitation, but it was not successful. So you will say that the patient has got circulatory arrest or circulatory death. Neurological criteria is used for brain dead patients. They are used following devastating brain injury in patients on an intensive care unit who remain deeply comatose, have absent brainstem reflexes, and are apneic, with their lungs being mechanically ventilated, but in whom circulation and other bodily functions persist. So you have your organs are working fine, but your brainstem is not working. So that patient is considered as dead, and we have to perform certain tests before labeling this patient as brain dead. So I'll discuss about all these tests. What are the tests for brainstem reflexes? What is apnea test and how it is performed? Before using any of these diagnostic criteria, the competent individual diagnosing and confirming death must be satisfied that there are no further appropriate therapeutic options left which could benefit this patient. In Europe, the doctor is not the one who diagnoses. The, the person can be a doctor, but it is not mandatory like India that only a doctor can diagnose. Anyone who has got knowledge, who is competent enough, can diagnose the patient as dead, especially in cases of somatic and circulatory arrest. However, for neurological criteria, you require two doctors as per the European guidelines. So, when correctly applied and satisfied each set of criteria distinctly, you can say that the patient is dead. I have mentioned the definition of death in my last para, that permanent cessation along with of consciousness combined with permanent loss of the capacity to breathe due to permanent cessation of the brainstem. So I'll be mostly covering about the neurological criteria. I have touched upon the somatic and circulatory criteria. They are pretty easy to understand. So neurological criteria is used when death is suspected to have occurred in patients following a devastating brain injury who remain deeply comatose. That is, their GCS will be less than 3. Or sorry, GCS will be 3, not less than 3. The minimum GCS is 3. They have no observed brainstem reflexes and are apneic, with their lungs being mechanically ventilated, but in whom circulation and other bodily functions persist. So the confirmation is a clinical diagnosis that should be made by at least two doctors who have full registration with the GMC for more than 5 years and are competent to diagnose and confirm death using neurological criteria in the UK. And one of these doctors should be a consultant. So this is very important for somatic and circulatory death. You don't require a doctor. Any competent person can diagnose. But for neurological criteria, in UK, you require two doctors and one of the doctors must be a consultant. Those diagnosing and confirming death should not be acting on behalf of the organ retrieval and transplant service. This is very important. This was asked in one of the questions. And they must not be involved in allocation of any of the patient's organs or tissues that may be subsequently be donated for transplantation. So they should not be a part of organ retrieval and transplant service, and they must not be involved with the allocation of the organs, like this organ will go to this person. This is applicable in India too. So American Association of Neurology, they define brain death with three cardinal signs. First is cessation of function of brain, including brainstem. Second is coma, that is unresponsiveness. And third is apnea. So for brainstem diagnosis, we need to have absent brainstem reflexes, and there are six brainstem reflexes. You must be knowing all these six brainstem reflexes because this can be asked in one of your questions that this reflex was absent, but that reflex is not a part of brainstem reflexes, so you cannot label the patient as brainstem death. So all these six brainstem reflexes should be absent, not just three or four, all the six. Absent bilateral pupillary light reflex, absent bilateral corneal reflex, absent Doll's eye movement or oculocephalic reflex, absent oculovestibular reflex, absent pharyngeal reflex, that is the gag reflex, and absent laryngeal reflex, that is the cough reflex. I'm not going into the details of all these brainstem reflexes, but these six brainstem reflexes should be absent. The diagnosis of brain death is clinical and confirmed by apnea testing. This should be performed twice. Now, in India, there are guidelines that you need to perform this apnea test 6 hours apart. But there is no mention of time in European guidelines. You just have to perform this apnea test twice. And before both these tests, you have to uh, achieve certain prerequisites. Once your apnea test is positive, that means your patient is brain dead. There are certain ancillary tests also. They should be performed when a comprehensive neurological examination, including apnea test, is either not possible or had to be aborted because of certain logistical reasons. So for at that point of time, you need to have these ancillary tests also. And in certain court cases also, you have to have this ancillary test as per European guidelines. So what are the ancillary tests which are available? DSA. In DSA, we will have absence of intracerebral filling at level of carotid bifurcation or vertebral arteries. CT angiography, which is safe. Then transcranial Doppler, where we have presence of diastolic reverberation flow with little or no forward flow. This is the diagnostic. And in EEG, from 18 to 20 channels, if we do for 30 minutes, there is isoelectric recording. All these are ancillary tests, which may be sometimes required along with your apnea testing.